Well, good morning. My name is Dave Flum. For those of you who don't know me, and for those of you who know me, my name is Dave Flum as well. It's my pleasure to introduce our Grand Round speaker today, Dr. Josh Liao. Josh is an internist, an associate professor for medicine at UW. He's the associate chair for health systems in the Department of Medicine. That's a new role that I think Josh maybe have a chance to talk a little bit about with us as well. Across UW Medicine, Josh is the medical director for payment strategy, and he's a national expert in healthcare payment and delivery policy. He advises state and federal policymakers on payment and care delivery, including the U.S. Department of Health and Human Services, as a member of the Physician-Focused Payment Model Technical Advisory Committee. Those of you in the Department of Surgery may know Josh because he's a close collaborator and mentor for many of the Department of Surgery research fellows who work out of Source. He's been a partner with Source faculty on multiple grants and projects. He has a very unique ability to blend the sciences of health economics, psychology of decision-making, and human behavior to ask very provocative questions. His work with residents, your fellow colleagues, are asking questions like, how do surgical patients perceive risk? How do we better communicate risk? How do we influence decision-making so people make the decisions that are best for them? How do surgeons make decisions? And how can they get better decisions or the decisions they intend? These are provocative questions that blend a lot of different areas of science. He is a prolific researcher, and in just a short couple of years at the UW, he has gotten something like 4 or 5 R01s and over 200 publications. He asks really great questions, but more importantly, has a really great way to communicate them. I first got to know Josh working with Dr. Pellegrini in the CMO's office, and he was able to translate very complex payment policy to thoughtful, insightful approaches for the system. I think really sensitive to the interests of our time, though, he's asking a super provocative question about whether or not the use of payment policy can have us achieve much more important goals than economic viability, but actually accomplish something in the space of healthcare equity. And that's the topic that Josh is speaking with us today. Josh, we welcome you to Grand Rounds in the Department of Surgery. Thank you for joining us.
Thanks, Dave. I'm glad to be here. Unfortunately not in person, but glad to be with all of you virtually. And as Dave mentioned, I'm fortunate to work on a number of different areas. Some of the decision-making work won't be the focus of our time today, but I want to just say is, in my mind, very inextricably tied to payment. You know, you can determine a way of paying for healthcare and surgery, and then a group of people, surgeons, nurses, pharmacists, service line administrators, and then patients and their families have to make a series of decisions about how to then go forward. And so those are really connected to me and highlights the work Dave mentioned. With that said, I want to just jump in with a few things and just say that the views that I expressed this morning are mine and not those necessarily of my employer here at UW. I also want to note that I do receive grant funding from a few entities, the National Institute on Minority Health and Health Disparities, as well as the Agency for Healthcare Research and Quality for large multi-year projects that focus on studying payment and equity issues. So with that said, I really wanted to ground our time together this morning on the why, right? I don't make any assumptions. Maybe there are a few of you out there, or a number of you that are independently interested in payments that have economics, actuarial backgrounds. My guess is that a lot of us here this morning don't. So the fundamental question is, why would a group of clinicians, in particular a group of surgeons, benefit from understanding this topic of payment and the equity implications of that? And so I'll try to make that case here now. I think the most foundational point is that payment is a powerful motivator in healthcare. That might seem overly obvious, but I think it's worth saying that a lot of what happens and doesn't happen in our healthcare system, in my view, is really emerges from and is wrapped around systems for paying for healthcare. The second is that many aspects I would say of clinical care, but in particular surgical practice, can be linked back to payment. If we think about kind of the forces and the encouragements in the outpatient side in clinic, for instance, to make sure we're capturing complexity in the form of codes, capturing the right level of service, so to speak. On the inpatient side and surgical side, even how and when we schedule services, what days of the week we do it on, start and stop times. In the hospital setting, how we think about supply, device costs, between cases, turnaround times, after cases, pressures around length of stay, even beyond that, how we think about delivering care in the context of 90 or 10-day global payments. All of those things, I think, what we see in clinical practice, and I would make the assertion around surgical care, can be tied pretty directly back to payment in some way. And I think that this link includes encounters with disparities, right? That particularly given the populations and the communities that we serve, we see and come up against disparities, particularly facing those historically marginalized populations. And I think we see that. And I think, again, I would make the case you can tie that at least partially back to the payment systems in place. So, putting that together, I would say, understanding payment and its link to disparities offers really important context for not only how academic surgeons deliver care, but also how they educate and do research and work and practice. And, the contemporary trend, there have been multiple ones, but I would say the major contemporary trend in payment has been away from a volume-based system towards what people term value-based payment, or VBP. And so if we kind of step back and kind of say that payment is a major motivator or driver of healthcare, and it affects the practice of surgery and medicine more broadly. And one of those ways we see that is through disparities of care, particularly those facing those who've already experienced longstanding disparities. And it affects how we work. And this overarching trend is towards value, then really understanding the equity implications in the context of this value-based payment for surgery, to me, is a relevant topic now and going forward into the future. So that's where we'll spend our time this morning. Now, to do that, I want to answer a few questions together, right? The first and most fundamental for the group, and convince me here, what are the major types of value-based payment for surgery, and do they work? So we'll talk about that briefly. The second might be, how do these models for surgery engage historically marginalized communities? And by engaged here, I mean, how are they offered to these communities? So conditional on them working, question number one, do these communities have access to these payment models? The third, cascading from there, is if they work and these communities have access to them, what about the actual disparities for people getting care underneath these payment models? And finally, to the extent that there's some limitations or rooms for opportunity in any of these other questions, how might we do things better? And as I'm signaling here, I think we can, and I'll highlight 4 ways to do that. So at the risk of everybody signing off now and just calling it a morning, I'm going to give you the bottom line on top here. I'm going to start with the takeaways. I'm going to leave you 6 things, okay? And I won't take it personally if you just wrap grand rounds here, but I want to give it to you, and then we'll step through them. I'll try to lead us to each of these 6, okay? So the first idea I want to leave you with is that value-based payments, there are many different kinds, but the fundamental thread is that they hold clinicians and organizations financially accountable for the quality and cost of care. In other words, the payment itself is contingent on the quality and or cost of care in a way that other payment arrangements are not. The second takeaway is that major value-based payment models for surgery, there are a number of them, but the 2 I want to leave in your mind are what we call bundled payments and ACOs, or accountable care organizations. And my case here is that they've shown some early and sustained benefits. The third is that, even if bundle payments and ACOs for surgery have led to progress in care delivery, unfortunately, in my view, they haven't necessarily translated into progress in equity, setting up our time together this morning. The fourth of 6 is that that these models, even if beneficial, have unfortunately excluded historically marginalized communities based on evidence that I and others have done. And then the fifth is that, unfortunately, there's a dearth of data about, okay, within these models, what happens to disparities for certain groups of patients. I think there's a real gap there in data. And finally, I think there are a number of ways to improve equity through these types of payment models. I'll highlight 4. The first is to make sure we're incorporating multi-stakeholder perspectives. The second is to set a policy intention and goals, and by that I mean payment policy. The third is to formally incorporate equity into the concept of value. I'll unpack that. And the fourth is, to the extent that we motivate what we measure and we change those things, to really make sure we're implementing programs that put equity as a centerpiece, and then we're evaluating those things. And as we go through all this, I'm fortunate to share about my research and the research of colleagues. As Dave mentioned, this is an area of focus for me, part of my career's work. So with that said, jumping right into the first question. So what are these major approaches, and do they work? What you're looking at here is a partial, non-exhaustive list of different ways you can pay for healthcare. And besides being convoluted terms, I think the idea here I want to leave you with is there are many ways to do it. And they're not mutually exclusive, right? That these can be braided together, paired, sequenced, combined in different ways. If I take this list and I just turn it 90 degrees and I put it along a spectrum, it might look something like this, where going from left to right, you might say things on the left, things like at cost, percent of charges, FFS is fee for service. You might call volume-based payment arrangements. Spanning to the right, things like bundle payments, ACOs, MCOs, flavors of capitation might be value-based payments. So what describes that spectrum? I think two things. The first is quality incentives. So again, that the payments are contingent on meeting or exceeding certain levels of quality of care. And then the second are cost incentives. So meeting or exceeding certain level of metric around spending or cost efficiency. Now, again, I want to just highlight that it doesn't mean that people who practice under fee for service or more leftward payment arrangements don't care about quality or cost consciousness. That's not the point. The point is that the payment itself is not contingent on that. Whether that outcome is good or bad for quality or cost, the payment's the same. On the right, it's inherently tied to that. So I mentioned two payment models, bundle payments and accountable care organizations. So I want to just orient you to those two quickly. The first is bundle payments. What you're looking at here on the left is under a more traditional fee for service arrangement, pre-admission, hospital services, professional services, post-acute spending are all kind of paid out in a piecemeal fashion. And what bundle payments seeks to do, as its name suggests, is to actually bundle those services and then a payment for those services together in a coherent clinical arc of care on the right there. And the incentive here is to then set some arrangement wherein clinicians and their organizations try to deliver that same kind of suite of care, but in a way that's more cost conscious or high quality, okay? So bundling a payment for a set of services in a kind of defined episode of care. And you might wonder, well, what goes in that episode? And in a relatively recent article that I was fortunate to write with colleagues from Dartmouth and Pittsburgh, one of the points we make is that there's no one size fits all. And in fact, you see that. If you look back historically, there are different ways that people define episodes or different ways that they bundle payment for episodes of care. And without getting too much into the weeds, there are different ways to do that. So this is a figure from that article that we wrote and highlighting three simple stylized options. The first is probably the most common one, option A, where the bundle captures everything beginning from hospital admission all the way through discharge and then out into some period of post-acute care, often 90 days. There are other options. In B, you see instead of post, it's pre-acute, and then in C, it just focuses around hospital services. And suffice it to say that there are variable levels of evidence for this, but again, bundle payments is defined by what is being bundled. That's the first question. Okay, and historically, really, hospital and post-acute is where the models in the U.S. have been. That's bundle payments. What about accountable care organizations? So the best way I can describe this is that if you zoom up to like a high overall level, accountable care organizations seek to basically capture everything. If bundles are really around a discrete episode of care, organized around a setting, hospital care, et cetera. ACOs really are meant to say globally, we take a population view all in, surgical, medical, primary care, subspecialty care in the hospital, right? So just to kind of show you that pictorially, if that red box around bundles is meant to capture that part of care, ACOs really seek to widen that aperture, basically say, what if we think of it, all of the spending, all of the quality, all the utilization, and apply some incentive there, okay? And so you can see how in both of these cases, they apply very much to surgical care. And to the extent that surgical care plays a key role in many people's healthcare, it represents a major component of both bundle payments as well as ACOs. So I framed the question as, do they work? And before we do that, I want to just orient us to the methods by which we study that, right? And almost everything I show you today, the work that I do, is based on the types of methods you're going to see here. And I just want to comment on that so we're thinking together. The premise here is that when we study things like bundle payments and ACOs, it would be nice to have a randomized experiment. But unfortunately, that just doesn't work. That's not how policy is often done. It's infeasible. And so there's an inability to randomize and test these things in experiments. But what we can do is we can look for methods that help us recreate those experimental conditions. It's retrospective, we look back, but can we use some statistical methodology to recreate those conditions? And so we call those quasi-experimental. Again, you're trying to recreate those conditions best you can, methods. And the answer is that yes, we can. They're not perfect. but we can get a large way there. And there's a whole basket of like approaches under what someone would call quasi-experimental. The one I want to introduce you to here briefly is called difference in differences. So that's hopefully the most technical thing I'm going to say to you this early in the morning. But the next time you flip open a journal and you see, oh, an evaluation of this payment model, the money is probably on difference in differences, okay? So what is the intuition behind it? You're seeing a figure of it, and again, this is looking back retrospectively, but if you can't randomize and have a control group, green line, and an intervention group, the red line, what you can do is you can look back and find a group that was exposed to a certain policy, in this case, a payment model, and a group in the green, the lower line that is not exposed to that, and you can trend them forward in time. And that vertical line is denoting kind of when the policy or the program or the thing you're trying to measure began. And so the intuition is that if before that payment model or the policy, the lines were parallel, there was a difference, right? The red line, the one above is higher than the green line, but it's consistently so. There's no difference in the difference. It's a stable difference. But that once the policy starts, suddenly you see the intervention group, the red upper line diverges, right? It's no longer on that dotted line, it moves and it flex up. Then there's suddenly now in that post policy period, there's a difference in the differences, right? It's that angle between that dotted line and the solid line on the top. And so that's what we are measuring. We're using these statistical methods to capture if the difference changed after the policy came into play. And we use that to infer some type of impact of the policy. So when I show you things and I say the difference in difference model showed X, it's really saying people in the bundle payment versus people not, people in the ACO versus not, and incremental changes after the ACOs or bundles came into existence. So with that, do they work? I'm going to buzz through these pretty quickly. It's not the focus of our time necessarily. This was a 3-year evaluation of the largest ACO program in the country, run by Medicare, from colleagues in Boston, and they used the difference in difference methodology and claims data. And they found this. So these are forest plots for those who are less familiar. And on the x-axis, you're looking at the unit of the outcome that are changing. And so in this case, it's dollars, right? So if you look at the x-axis, from the 0 to the right would be increased spending, a difference in the difference. So differential increase in spending if the points are to the right of the solid vertical line, and then a decrease or savings if the point and the confidence interval to the left, right? If the confidence intervals cross that vertical line at 0, right, no statistical difference. And so what you take away from this is that looking at ACOs organized by physician groups and hospitals, the takeaway is that the physician group ACOs save money, the hospital ACOs do not. And I'm happy to answer more specific questions, but the high point is that they do save money. What about quality? What we see here is that in terms of quality, that ACOs compared to non-ACOs decrease ED visits differentially. And there are no other changes in these things you see here: primary care visits, ASCs, ambulatory sensitive condition hospitalization. So those are things like, you know, if you were able to manage diabetes, would they not come in with DKA, et cetera, and readmissions. And so the bird's eye view here is that ACOs compared to non-ACOs, they save money and they might have some quality improvements in terms of ED visits, slightly improved to stable quality, okay? And that's really carried the day for ACOs as like if it derives benefit. What if we take that same methodology and we apply it to bundle payments? So this is work from colleagues at Penn that I did with, looking at bundle payments, the same way we described it, hospital and post-acute services, looking at joint replacement surgery. Why joint replacement? It ends up being the most high volume episode and the one that most people participated in. So it has the most sample to evaluate. Similar methods. And what we found, here's another kind of forest plot showing it. Again, you're looking at here percent spending. Okay, so again, against that control group, what you saw in that picture, compared to that, BPCI hospitals and their clinicians. And what we found is that they save money on the order of a few percentage points, 1 to 2, 3% less in spending compared to controls, okay? And what if we look at quality? There were no differences that we found in readmissions, ED visits, complications, mortality. So again, the top line here is that bundle payments save money and they don't compromise quality. Starting to sound familiar with ACOs. And that is also derived into this message that for surgical bundle payments, there are benefits in the form of cost savings. with no decrements in quality. Just so you know, I'm an internist, and so I studied this as well for medical conditions. And so this is a paper that we published in the Vertical Medical Journal, looking at that. Similar setup, similar programs. We looked at things like myocardial infarction, heart failure, exacerbation, pneumonia, et cetera, instead of surgery. And starting to look repetitive, right? But we found a couple things that you see decreases in total episode spending at about, again, negative 1.2%. So a 1.2% savings in the bundle payment program. Where does it come from? It actually comes from decreased skilled nursing facility utilization and spending in that post-acute period. And again, we found stable quality as well. So there's a theme that's emerging here, I hope you see, which is that these quasi-experimental methods show that these large models that affect surgery are saving money, and they're not compromising quality, at least best as we can capture in the data. There's a grant that's actually beginning underway, one of the ones that Dave mentioned, that will be actually focused on studying major bowel procedures and other surgical outcomes. I don't have those data to show you, but I want to show you just some from formal evaluations that Medicare asked the contractor to do for these programs, right? Just to give you a data point here. These are not independent, they're not peer reviewed, but I think just a nice context. So the first is they evaluate bundle payments for major bowel procedures. And what they found was lower spending, as you see there, in a few different forms, and what I'll interpret as stable quality. Okay, that's for major bowel. What about for gastrointestinal obstruction? They actually found greater spending and greater unplanned readmissions. And so you might interpret this as more spending, potential concerns about quality. I think the third one is something that maybe surgeons may be engaged in the care of esophagitis and other digestive disorders. Here again, you see lower spending and perhaps some gains in quality, lower unplanned readmissions. So what do you make of this slide? And there are many other episode types, right? But CABG, vascular surgery, et cetera. What you can make of it is that there's variation across types of surgery, but that overall, if you kind of take a fuzzy kind of magic eye view, there are overall benefits to these programs. So summarizing just these points here, value-based payment models like bundle payments and ACOs are designed to hold surgeons and their organizations accountable directly for the quality and cost of care. Oftentimes, these bundle payments encompass hospitalization up to 90 days of post-acute care. It's that option A I showed you a few slides ago. And the results vary, right, by ACOs and bundle payments, but for the most part, they've demonstrated positive benefits in the form of some cost savings, no compromised quality. Okay, so to answer that first question, bundle payments and ACOs are those predominant models for surgery, and they seem to work at least somewhat. So second question, how have these models engaged historically marginalized communities? And so the idea here, this is a body of work that I and others have done for a number of years, saying, you know, if these things are beneficial, in other words, if it costs less and the quality is no worse and maybe even a little better, then it's important that different communities have access to them. And so this is a paper that colleagues at University of Pennsylvania did, where they basically just looked at what physicians enrolled in ACOs. And I can't say it better than them, so I'm just going to throw the quote up and read it. And what they found was that physicians in areas where a higher percentage of the population was Black, living in poverty, uninsured or disabled, or had less than a high school education, had lower rates of ACO participation than physicians in other areas, or as the title suggests, in more affluent communities. And so it raises the question again of whether there's a selection away and whether these communities can actually get into these payment models like ACOs and get benefits from them. Is that isolated to ACOs? We studied similar things in bundle payments. This is a paper we published recently looking at a large joint replacement surgery model. And we asked a similar question. The measure we looked at was dual eligibles. Some of you may know that individuals who are simultaneously eligible for Medicare and Medicaid, they tend to be individuals that have higher societal risk factors. And so using dual eligible status can actually capture that. And that's been kind of fleshed out by the US Department of Health and Human Services as a measure to do so. So we asked the question, if we look at the proportion of people who are dual eligible across communities in the US that were affected by this program, what happens? And here's what we found, that the markets that were more likely to have a higher burden of adverse outcomes through societal risk factors were less likely to be selected, CJR is the program, for this program. Let's put some numbers on it. That means is you take the communities with the lowest proportion of dual eligible, higher risk individuals, and you go to the highest concentration, that would be quartile 4. As you move from the lowest quartile to the top quartile, there's a 14% lower likelihood of being in this program. We translate that into English. The communities with these higher need individuals don't get into this program. And so if you believe that programs like this, as I showed you earlier, derive benefit, it again underscores whether these communities have access to these payment models for surgery and access and equity issues. Okay. So the summary here is 1 point. It's straightforward. It's unfortunate, which is that major value-based payment models for surgery can, and in some cases, have excluded historically marginalized communities in the ways I just described. So moving to the third here, how have major value-based payment models for surgery affected disparities among individuals in those communities? Okay, Josh, you told me these things work on a high level, that there's some access issues at the community and geographic level. What about the people that do get the care under these models? How do they do? And as I signaled to you earlier in the takeaways, there's a dearth of evidence here. I'm fortunate to serve on a committee that advises the Secretary of the Health and Human Services at the federal level. And I said this very point to them a number of weeks ago, that we need more data here because there's just very little of it. Now, that said, I want to preview some unpublished work that we're getting together to submit for publication, but it basically goes back to this paper I showed you before. So this is based on medical episodes, bundle payments. I showed you this a number of slides ago, looking at what happens under bundle payments for myocardial infarction, heart failure exacerbation, pneumonia, sepsis. And you saw this as well. There's episode savings. It comes from lower skilled nursing facility utilization and spending. So we took these results and we said, okay, this is the overall result. But if we take this and look at it by dimensions of clinical risk, advanced age, severity, frailty, disability, what if we identify facets or dimensions of social risk that we can see in the claims, race status, dual eligibility? How do these people perform? In other words, are the benefits under this bundle payment model isolated to certain types of people, or can we see even benefit across these measures? And same forest plot. And what we found, you can see here, looking at SNF length of stay, because we saw that's where the spending decreases were, right, and where the benefit was. And what you see is variation there. But in terms of the length of stay, what we see is, for example, in certain groups, the length of stay is differentially lower under bundle payments. Some are differentially higher. A number have no difference. And one of the takeaways for us early in this work is that there's not a blunt instrument we're doing. We're not just saying for all bundle payment patients, regardless of your status and these characteristics, we're just going to do this to you. So that was partially reassuring. One of the things we did as a counterbalancing measure, we said, okay, if SNF spending and length of stay is where the benefit's coming from, we need to make sure these people aren't being harmed, right? Through what? Perhaps bounce backs and readmissions. So we looked at that as a co-primary outcome. So you're seeing here is 90-day readmissions. And I think the figure tells the story, but we didn't find any differences in readmissions for any of these groups, which is, again, reassuring. And so, again, this is early work. We are going through sensitivity analyses. We're applying this framework to surgeries, major bowel, spine, ortho, cabbage, vascular, a few others, with the same lens to say, how are people doing based on whether they're in these groups or not in these groups? I want to summarize this and make a point here that seems a little technical, but is really relevant to our conversation here, which is that some data, the data I just showed you, shows that there are early data around historically marginalized groups, but there is almost no data for the disparities between the groups. And that's actually what I just showed you. What do I mean by that? Let's say you find that a payment model or a policy or a program does something to overall outcomes, right? It actually doesn't tell you anything about the disparities in the outcomes necessarily. So I'm giving a scenario to illustrate that. So say you find that a program has no overall effect. It may be that actually is a result of being worse for certain groups and better for others, right? And they net out an average to be no effect. If you don't go looking for the disparities, you actually won't ever find that, okay? Here's another scenario. You find that there's a positive effect overall. A program works, a payment model works. But when you decompose it with the disparities lens, you find that actually some groups benefit a lot and other groups benefit a little bit. And so even if the overall trend is towards benefit, you might find that the disparity or the gap between two groups is opening up. And we have to ask ourselves, is that something we want or can tolerate? And so the data I just showed you around clinical social risk is, to my knowledge, the first cut at doing that in payment models, to ask that question of how the disparities change, rather than just saying overall, how do these models work? So again, these models work. They have access issues in the sense that they exclude certain communities that have been historically marginalized. And what you should take away from this is that we just have very little data about whether people do better or worse in these programs compared to other patient groups. Okay. So finally here, I want to answer and flesh out this point. What are 4 ways, conditional on these issues, right? Access issues, inclusion, exclusion issues, lack of data issues around disparities. How do we better advance equity through alternative payment models or value-based payment? And so this is an article that I was fortunate to co-author earlier this year that basically calls attention to this issue. And this article really was the kind of the conclusion of 5 to 6 years of work studying this and really grappling with a lot of the thorny issues in payment. And it makes 4 points. And the first one is that we think of disparities as an unintended consequence, the unintended consequence, the unintended consequence. And that always bothered me personally, because I think I believe policy intention should always come before policy implementation. And that one of the things that entrenches disparities as an unintended consequence is if we don't intentionally design payment models with that in mind. So that's what I mean by set intention and set longitudinal policy goals. So we don't need to tell a group of surgeons the power and the limitations of metrics and goals, but I think suffice to say, it helps us orient to where we want to go. And so the point we make here is to set an intention and to set goals around how do we advance equity in payment. The second is to incorporate equity into the concept of value. What do I mean by that? Many of us think about value, broadly speaking, as quality over costs, right? Take it out of the healthcare context for a second. You and I are buying a good, a device, a car. If that, whatever quality that thing is, if it costs us $1, it might be very, very, very high value. If it costs us $2 million, it's probably very low value, right? So quality over cost is how we think about it. The problem with that equation, so to speak, is it does not incorporate equity, right? It puts a premium on the biggest proverbial bang for our buck. What's the best quality for the lowest cost? It doesn't inherently ask what's the most even bang for our buck. Are all groups by race, ethnicity, by social risk factor? Are we getting the same benefit? Are we avoiding harms in all groups? And I think that's a limitation. I think that currently statute does not allow that to happen. And my colleagues and I have advised the policymakers essentially on this point that you need to actually incorporate that informally, or else we're going to miss it. The third, kind of cascading from these more kind of principles, is really to identify changes we need in measurement and evaluation methods. So colleagues and I have engaged in conversations with groups like the National Quality Forum and other groups that are defining measures for these models to ask this question. If we don't improve what we measure, how can we measure this in a way that it actually doesn't harm people? Do we really want to measure performance by race, ethnicity, SES? Maybe, maybe not. It's a challenging topic, so we need to really get people in room to do that. And the final thing is, as I say, I think we really need to know, do the things we do in these payment world, do they work, right? And so the evidence I just flashed on the screen for you in preceding slides is my attempt as an independent researcher to try to do that. But I think we need that from governmental evaluation, from independent groups, from researchers, et cetera. We need to evaluate the things we implement. So those are 4 things that we've called for. And I'll tell you kind of that I've been edified by the fact that I think policymakers have listened. And I think that many of the more recent announcements from groups like Medicare have reflected a lot of these principles. So I want to kind of wrap here in the next few minutes by, but I want to leave you with one way. You say, okay, that's interesting, Josh. I've learned some things here. How do I kind of support this message? Colleagues and I have recently started an initiative called Health Equity and Payments. And the initiative builds off of that article I just showed you. It's an initiative that working on building coalitions and collaborations to really promote equity rather than perpetuate inequity through payment. How are we going to do that? We're going to do it through a few ways of achieving these goals. We're going to convene stakeholder groups. This includes payers, insurers, healthcare providers, physician practices, frontline clinicians, patients, advocates. We really need to have all these voices in the proverbial room to be able to address this issue. We're going to partner with the groups I just mentioned across the country to try to address inequity. We're going to create implementation roadmaps, right? Like you might hear what I'm saying and say, that's nice, but how does this actually touch the ground, and how do surgeons and their practices like do this work? And so we'll be doing that. We're actually going to try to launch programs. We're actively working with, again, insurers and healthcare organizations to say, if you're serious about this, let's implement a program, right? Talking about principles is nice. We need to put some data into the world. So we'll be doing that. And then certainly we'll try to evaluate what we implement. So this is a new and ongoing thing. As a first step, just to raise awareness, colleagues and I put together a call to action around this, articulating and summarizing some of the things I just talked to you about. We've been fortunate to get sign on from a number of individuals, ranging from clinicians to professional societies, and actually including leaders at UW Medicine, including our president, our CEO, I'm sorry, and the dean of our medical school. And any of you that are interested, I welcome you to visit healthequitypayment.org, where this letter is housed. There's a chance to learn about what we're doing, to sign up for updates. I highlight this not as the only initiative that's happening here, but one that's near and dear to my heart. And that is kind of like one of the next steps, I think, of all the things I've shown you. Payment is a powerful motivator. It affects so much in healthcare. They seem to work, these payment models, but they have these equity issues and disparities implications. So what's next? And I think, as I told you in an early slide, value-based payment to me has been the arc over the last decade. As we look forward to the next decade, I think a lot of us who think about this every day don't want us as a community to recreate the same errors, right? We want to do better. And so this is just one way that we can do that. So anyway, welcome anybody to engage in this if interested. Before I conclude here, I want to just say thank you to my team, staff, collaborators. This is a partial list, but represents the people that contributed to the work I just showed you in prior slides. Needless to say, this work doesn't happen without a team effort there. So revisiting the takeaways, let's see, you keep me honest here, see if we hit these, but these are the same 6 you saw earlier. The first is that value-based payments are arranged that hold clinicians and their organizations financially accountable inherently for the quality and cost of care. There are a number of payment models, but for surgery, bundle payments and ACOs are relevant ones, and at a high level, they've been shown to have some benefits. Those benefits, unfortunately, I don't believe have translated into progress in equity or closing disparities. In particular, from a geographic, can people access these models perspective, I think these payment models for surgery have excluded some historically marginalized communities, unfortunately. When we ask the question about disparities under these models, there's a dearth of data there. I've showed you some early emerging work. More needs to be done from my group and others around the country. And finally, I think that conditional on these issues, there are just ways that we can do better. And they begin with principles, but they cascade into real action and evidence. And I think it begins with making sure we have perspectives from many stakeholders in the healthcare community, setting attention and goals for progress, incorporating equity into the concept of value. And I mean that hard coding. I don't mean like this nice idea. I mean putting it into statute and how we think about value, and then implementing programs and evaluating it. So that was a lot. I appreciate your attention. I will pause here, and I just want to end where I began and say, I hope that even if some of this detail maybe is not the most relevant to what you're going to do today, this week, and the month, I hope that in a moment of reflection, we can see how payment drives so much of our experience as clinicians and yours as surgeons. And my bet here, and we can revisit this, and you can hold me to it, is that in the coming years, as you teach people, as you do research, as you practice care, these things I think will be increasingly relevant to care. And we'll look back one day and see that slowly and incrementally, these changes have happened. So thank you for your attention. I appreciate it. I'm happy to take questions.
Dr. Liao, thank you for a fantastic presentation. I think for so many of us, as you say, we care about the care that we provide and we think about the money, but I think that's kind of not where we come from, right? That's not kind of how we train, but the impact is so profound. I really thank you for not only pointing these out, but also kind of helping us to orient our own surgical practice. We are going to start some question and answers, and first we'll leave it open for those who want to actually speak and ask their own question, and then we'll also moderate chat. So we'll start with Dr. Flem, who I know has a question.
Dr. Liao, great talk. Thank you so much for that really lucid presentation. And I think it's an example of how you've been able to translate health policy to real issues beyond dollars and cents. And I think I'm glad the Department of Surgery got a chance to hear that. I particularly thought that comment about building intentionality into policy related to anti-racist and anti-biased components is so fundamental. And on that, I'd like you to think about or talk a little bit about two aspects of bundle payments that are relevant for surgeons. The first you talked about related to bundle payments, that the big story about bundle payments is that if you want to save money for surgery in a bundle payment, don't do anything in the healthcare system, on the hospital side of the healthcare system, squeeze the skilled nursing facility and look at an outcome of readmission as a sign of whether or not that's working. It seems to me that is inherently ableist and problematic for people who rely on skilled nursing facilities for supportive care. And strikes me that looking at readmission, which itself is an access outcome, is problematic if you're trying to figure out whether or not reducing skilled nursing facility use is a good thing or a bad thing for communities that are struggling for any number of reasons to get access back to the healthcare system. So the first is the problem of SNFs, and readmission is the measure of whether or not reducing SNF utilization is helpful. The second thing I'd like you to address is that overutilization and underutilization are interesting components of disparities. And bundle payments really don't do much to address appropriateness of care. We know that when there are racial disparities, sometimes it's a curious overuse of surgery. Hysterectomy for fibroids comes to mind, or underuse, lack of access for life-saving or quality of life-saving surgery. How do you think bundle payments are going to change to handle that aspect of disparity? So if you can maybe get it, we'd love your thoughts on those two issues.
Yeah, I appreciate the questions. Let me just say, I appreciate where you started your comments as well. So I'll meet you there on a foundation and say that whenever I approach studying a group, people with disability, people from a certain race identity defined in the data, I'm always very cognizant that that these issues are multifaceted, that what's coded in the data doesn't equal lived experience all the times. So taking race as an example, being coded as with a race identity of Black does not equal the lived experience of that, or the experience of racism, or race centrality, or ethnic heritage, and a number of other things. And so I always try to pass the work that I do through that lens in the many dimensions that we talked about. So that informs my work. I think to your point about disability and ableism and bundle payments, I agree that readmission, there's no measure that's perfect. And so, the tension that those of us who do this work struggle with is you have to measure the things that are measurable, but then you have to push advances in how we capture data to get these other outcomes. The things I often hear from clinicians, the things I think myself when I'm taking care of patients is like, I would love things around functional status, experience of care, et cetera. But we just don't have that readily available. And I think that's one of the issues. Actually, in that initiative I talked about, that's one of the things we need to capture better data. Now, that's easy to say, right? And a lot harder to do. I mean, who's got the time and what's the system? And so it's nice to think about those things, and we have to then, put it into action. So I agree with that. And I think my hope is that bundle payment models of the future capture data better, in a better way, in a more comprehensive way. And that we'll look at things outside of skilled nursing facility. I think you're beginning to see that. Bundles used to be just in the hospital, then it was 30 days, now it's 90 days. And I don't know, I didn't bring my crystal ball, what the next thing will be, but I think there's a move away from just pushing the skilled nursing facility. I think there are limitations that people recognize. As to your second question, yeah, I agree. I mean, the reason I think it's so important to formalize equity into definitions of value is this very issue of over and underuse simultaneously. So a lot of my work is focused around joint replacement surgery. And what we found there is that the reason it's such a target is because nationally, if you step back and look at a macro view, there's a lot of utilization, it's high spending, the trend is going up sharply, and there's a desire to kind of curb that. But what we also know from decades of research is that certain groups, take, for example, Black or African American individuals, they underutilize joint replacement surgery. And that's complex and multifaceted, but they get it less. The way they utilize skilled nursing facilities and post-acute care is different. And so if you believe there's an underutilization there, I don't think we can take a blunt instrument like bundles and just say, okay, let's reduce utilization, because you would then worsen that issue. Put it a different way, I think payment models in the future, including bundle payments, need to acknowledge that there are going to be times we should spend more money if the value that we're getting out of it, defined by equity and quality, if we're getting that back. I'm hopeful that will be the case. I think we have an opportunity with this current administration and going forward, what they've just released about equity focus. And so I'm hopeful, but hard work is is needed in these areas.
There's 2 questions on the chat that I think kind of follow from one another, one from Dr. Labadie and one from Dr. Elia. And Dr. Labadie asks, why do you think marginalized communities have often been excluded or have lower utilization of value-based payments? And kind of to follow that, Dr. Elia said, perhaps is some of the benefit in value-based payments that we're seeing because marginalized groups have actually been excluded from them?
Yeah, both great questions. Thanks for asking them. And I would say, my own opinion about why those communities have been excluded is that is a few things. I think one, Halloween just passed, and if you want to scare someone like me who, works on understanding payment models, dress up not like the boogeyman, dress up as selection, right? Patient selection, and walk around, and I'll be really nervous about it because in every payment model, there's this risk of selection. What I mean by that is that you can choose which patients are in or out of the program, right? And of the people who get into the program, you can kind of differentially select the types of care you deliver to those patients. To Dave's point earlier, how and when do I suggest people go to SNFs, et cetera, et cetera. And so I think, why do I think they've been excluded? I think that partially is that there's this issue of selection in these models. The other thing is very process, which is that these models generally allow you to, right? So if you allow hospitals and groups to decide I'll get in or I won't get in, there is a selection that happens there. And so that slide I showed about ACOs, right, is a classic example of that, where a physician group or practice may say, we are in an area where we serve a community that if we get into this program, we're going to be penalized greatly. So let's not get in. And that's anecdotal, right? But that's something that we have seen in the field, so to speak. And so I think that's a major issue. These models are voluntary. They allow you to select. And I think that there is selection out there, and people serving those communities may not get into these models. Now, what's the implication of that is like actually the second question comment, which is how can we be sure that these results don't result from exclusion? And the point is that we can't be sure of that actually, and that's the major problem. In contrast to that ACO, model that I showed you, that the one that we looked at with the joint replacement was mandatory. So there is a movement everyone should be aware of where policymakers are thinking about making these programs mandatory. Now, the moment the word mandate comes out of somebody's mouth, everyone tightens up. But the motivation for it is actually that if you allow hospitals and physician groups to choose when to get in or not, there is this cherry picking. So one way around it is to just compel everyone to be in it. There's no shifting and cherry picking, everyone's in this model. And then the results of that model would be more generalizable and you wouldn't worry about exclusion as much. So again, that's a contentious thing. I think in the next couple of years, we'll see that play out in the policy arena, but we can't be sure any more than you can be sure that a clinical trial that enrolls a certain type of patient can be applied to people who are not in the trial, right? There's that limitation. You see the same thing here, but it's a deficiency in my mind that we need to address.
I have a question that may not be one easy to answer. So I spend the vast majority of my time practicing in the Veterans Health System, which of course of sort of care in that model based upon some of these other models that you've seen. Not so much the quality, but like sort of this volume, the money aspect of it.
And I apologize. I maybe it was my connection. I broke up there just for a second. But did you mean that the Veterans Affairs system has a different kind of financial incentive?
To some degree. I mean, to some degree, it's kind of almost like an HMO, although it's not. I mean, basically you own the patient no matter what setting they're in, and sort of how that impacts value for care.
Yeah. So I think the principle behind that when I think about that issue is that there is no perfect payment model. If I did, I would just wrap it up and call it, I wouldn't do this work anymore. And so I don't want to vilify fee for service as like the source of all ill here. I think that actually serves a really important role in healthcare, and that things that are more HMO or capitated, there are problems with it. I just think we haven't seen the problems because we haven't had the uptake we have as we have for fee for service. And I think not commenting on any one facility, I think in the VA system, you see some of the issues there related to that. So you're right, not easily answerable. I'll just say the VA system, in my view, on a high level, it highlights the issues that we could come into if we all became capitated. And so a question I often get is, so is the goal for everybody just to go towards value and be done with it? I actually don't think so. I think healthcare will continue to be regional and local, and it'll look different in different places.
So I know Dr. Wood and Dr. Sinanan both have questions. I'll let them speak their questions.
Hi, Josh. Thank you so much. I echo Dave Flum's comments. Going back to the ACO summary that you provided, it seems to me when ACOs were originally set up, the intention was to save a substantial or a significant amount of money and to improve quality. And what you showed was they saved a little bit of money, but didn't harm quality very much, pretty much. Has that changed the perception, you think, of ACOs and their implementation around the country as a payment model?
Yeah, so this is the thing where, and this is maybe a point I hope we can all take away from this today, is that I don't think it is like, there's a group of people working on designing models like ACOs, right, to try to make them work as intended. And I think sometimes when those groups of people, policymakers, people at payers, people who work with the payers, when we don't hit the mark, we get these issues where what happens is not what's intended. That's my personal belief. The thing with ACOs, it goes back to that point about equity definitions. If you look at statute, right, we can Google it right now together. It basically says that for this to be deemed as kind of a success, I'm paraphrasing, it has to save money and hold quality the same, or it has to improve quality without increasing costs, or it has to do both, right? Kind of like the holy grail of more quality at lower cost. And I think often people think of ACOs as the third, but it's designed to be the first. It's designed to be one that controls costs without compromising quality. And so for those of us who've worked around that for a while, I'm personally not that surprised that that's what came out, because if you pop the proverbial hood and look in, that's how the model is designed. And I think if we don't change that design, we won't see anything different.
Josh, Mika, did you have a follow-up? Josh, thank you. This was terrific. I learned a lot. I knew I was going to, so thank you for taking the time with us this morning. And yeah, I just want to emphasize the points that Dave Flum, Dr. Labadie, Dr. Elia asked. All through your talk, I was thinking about lowering cost by underutilization of appropriate services, particularly to marginalized communities. I'm going to ask you a different question. Yesterday, late yesterday, Medicare released their final payment schedule. And one important aspect of that was they had proposed bundling all critical care services into a global surgical period, and have actually in the final rule not chosen to do that. Any comments on that or other important outcomes from the Medicare payment decisions released yesterday?
Yeah, I appreciate the questions, and I think there are actually two things. So one is what was released yesterday, which you mentioned. The other thing that was released about a week ago was the Center for Medicare and Medicaid Innovation, CMMI, which drives some of these models, their kind of roadmap or path for the future. And they articulated things that they wanted to see in all of their future models. And one is actually inclusion of higher risk groups. So I think they've recognized that the results are not generalizable if you don't have those people in the models. And so whatever models come will incorporate those populations. And then I hope evaluations of that will be more generalizable to those. And we'll get at some of the questions that people asked in the chat. So I think that's actually worth people looking at if there's interest around what's the new direction for CMMI models. And I'll tell you, as somebody who's studied it for a while, it is a sharp left turn than what's come before. And I think in many ways good. What you're talking about is a little more incremental in the sense that there are these decisions in the fee schedule that kind of change or don't change. There are things that compress the E&M, expand the E&M. A couple of things I'll say there is maybe two things. One is that my view is that Medicare is taking its learnings from these payment models, right? Bundle payments, et cetera, and porting them over to the fee schedule. They're learning from that in a way. So what works, doesn't work, how they're doing it, that you can see kind of threads of that and how they're deciding globals, how they're compressing E&Ms, how they're creating cost measures, et cetera. And that leads to the second point, which is that even though we think about value-based payment models over here and the fee-for-service over here, there are these changes happening all the time in the fee-for-service world that are shifting us slowly, like almost without us kind of like really recognizing it, into this more value-based world, right? Such that like if you look at what fee-for-service means in Medicare in 2025, it'll look very different than what it looked like in 2005. And I can't comment on intent there, but that is certainly a move that way. So, you know, I won't comment on the globals per se. I'll just say that you can see lessons they're applying from value-based payment models into this fee schedule. I think that will continue. And I think there will be then in that way more and more emphasis on globals, on bundles, on kind of APCs and DRGs, in other words, bundling payment. I don't think that's going away, right? And I think it'll only be more so every fee schedule that's released compared to the ones before. Maybe one other thought I want to highlight that is that Medicare sometimes allows, and the CPT committee allows, new codes to be made, right? So many of you may be familiar with things like TCM, transitional care management from people leave the hospital, or CCM, chronic care management. Because of budget neutrality, right? When those codes come out, they have to decrease something elsewhere, and it's all anticipated. So what am I saying there? What I'm saying is that they make a bet about, okay, if I release this new transitional care management code, uptake will be X. There'll be this many 100,000 services, and I have to account for that in the payment. And then for budget neutrality, I have to then adjust the conversion factor for everything else, right, down. It turns out that actually in prior years, you don't always hit that measure. So if suddenly utilization for that is lower, right, what ends up happening is you have lower conversion for everything else, and they didn't have to pay out the transitional care management claims that they thought they did. That seems like a little inside baseball, but I'm just highlighting, Doug, that whenever you see changes in the fee schedule, there are actually these things that there are these losses where if they don't do globals, if they do globals, if they add this code, if they take that code away, something else is lost. And if reality doesn't square with their estimation, what that means is money leaves the whole system for everybody. And that's actually happened pretty consistently, and no one really talks about it. So I wanted to highlight that for the group.
That's a very interesting and somewhat sobering thought to consider.
It is, yes, it is.
Wow. Well, I think we have, gosh, we're like right on the money for time. Well, again, Dr. Liao, thank you so much for taking the time out early this morning to join us, to educate us, inform us, and also to kind of have some good discussion to help us think about this more and hopefully be a part of better things.
Thanks for having me.
Good job, Josh. Thank you.
Thanks, everybody.